morning. This is Kate Carpenter with the IHC Compass HEN. This morning, we've planned a brief session to give you an overview of our 30-day readmissions measures. I've got Kathy Tritton, the Senior Director of Information and Quality Management from the Iowa Hospital Association, joining me this morning. Today, we're going to share with you our 30-day readmission measures, the data sources that information comes from, and give you an overview of the measure methodology and specifications. I'll also provide you with a resource you can use moving forward. So we do have two outcome measures for 30-day readmissions in the Compass HEN. Those two measures are unplanned, all-cause 30-day readmissions to any hospital and unplanned, all-cause 30-day readmissions to same hospital or your hospital. The measure numerator and denominator descriptions are listed there on the screen. This is an excerpt from the full HEN measure set, which can be found on Hennovation. At this time, I'm going to turn it over to Kathy to share some information on where this data comes from and how it's reported.
Greetings, everyone. I'd like to introduce our data source that may or may not be familiar to you. As quality professionals or data analytic persons, you might be familiar with the requirement for participating hospitals in Iowa and South Dakota to submit claims-based data to a centralized location where that source is then used in a monthly way that I will detail. You should see a grid that explains monthly reporting or potential monthly reporting. The value that is gained by following this timeline helps your quality professionals, details information for more real-time analysis and understanding hospital performance. On or about the 15th of every month, if you are able, or the persons in your hospital that submit these data are able to send whatever records are available. That would mean, in the example that you see, for the month of January, if that is submitted on or around the March 15th, and then all records that are submitted would need to be cleaned of edits if they exist. On or about the 20th of every month, IHA pulls down any valid record that matches, that is included in the time frame being analyzed. Every month that happens, and you can see that by February 20th, we're now pulling down that any new data. We refresh these data in a routine way. For Iowa hospitals, a 90-day timeline is what you are used to for validated, finalized IPOP data. That means that 90 days from the end of a quarter, we will release finalized, verified, attested inpatient data to back to members, to any purchaser, etc. In South Dakota, the timeline is biannual, so each half of the year is released in a similar fashion. For both states, though, we do include a monthly result if there is one available. If data are available, that hospital will get some results. For the open months, I want everyone to understand that when we have an open month, in our example, February and January here, if a result is seen for an open quarter, it means that it is a provisional data point. Until that finalized data is available, changes to any of that hospital's submission and or any other hospital within that state could change the results for readmission to any hospital. So it's important when you're looking at these process improvement numbers to realize open quarters and provisional data. The measure methodology and specs has a history that I'd like to talk about just a bit. Since the inception of the HIN program, the Compass HIN has adopted a Yale or CMS-like methodology that attempts to take some key pieces. It is impossible to match it exactly, and we'll try to get into some specifics about why that is, but we attempt to do that. The result is to share any readmission to the same hospital or your hospital, as well as any patient that has an index admission at your facility and they go to another facility. You may ask, how is that possible within a data set? When records are submitted to the IPOP or the statewide databases, a patient linking ID is assigned. That patient linking ID is then used to match index admissions with the analysis to see if that same ID shows up again in the data within 30 days. Acute inpatient records from statewide databases are then examined to be so we can determine if that is an index admission. The databases search for that linking ID that I just talked about to see if that person came back for another acute visit. The readmission results that Compass HIN shares are acute to acute. They do not include behavioral health, distinct unit behavioral health, distinct unit medical rehab, or any SNF or swing bed claim. This result aggregates the numerator for a number of unplanned readmissions and a denominator, the number of index admission by hospital by month. There are similarities of what Compass HIN adopts compared to the CMS methodology. Acute to acute inpatients are examined for readmissions. Inclusions are only where patients are discharged alive or where the patient is not transferred to another acute care facility. There are also some exclusions that we copy. If a patient is discharged against medical advice, or if they are determined to be a medical or a rehab care as determined by the Agency for Healthcare Research and Quality, or ARC, Clinical Classification System, CCS 254. The principal diagnosis on every claim receives a CCS designation, and if it is 254, that account is not considered an index and not included. Where the patient was admitted for treatment of cancer and the principal diagnosis indicates that, again, they are not included. And finally, any record where the primary reason for admission is a psych diagnosis, they are not included. Differences from the methodology used by CMS, we apply this methodology to all payers. CMS obviously uses Medicare only. We apply it to all ages rather than 65 and up. It's applied to all admissions. CMS aggregates these and shares results on Hospital Compare for condition-specific readmission analysis, pneumonia, heart failure, AMI, etc. CMS has the ability to examine how long that patient has been enrolled in Medicare. We don't have that capability here, so there is no exclusion for being insured. And finally, CMS utilizes 5 cohorts: general medicine, a surgery gynecology bucket, cardiorespiratory, cardiovascular, and neurology. In our solution, we combine them into one. It gets pretty detailed here, and I'll try to explain it in the most concise way. If an index admission meets the criteria for being eligible, the patient ID, linking ID, is examined for the next 30 days. In a hierarchy fashion, if no later admission was found within that 30 days, obviously there is no readmission. If a record is found with that linking ID, it is examined to determine if there is a principal procedure on that readmission that is a planned procedure. I will get back to how those are determined afterwards. If the principal procedure on the readmission is in the always excluded diagnosis, it is still included, or it is not included as a readmission, it is not marked a readmission. Next, if a principal procedure on the readmission is in the always excluded procedure, now you could say, what's the difference from the planned procedure? There are 2 separate lists. If a procedure on the readmission has a principal or a secondary procedure that appears, and there's a principal diagnosis that is linked to that, it is also not included as a readmission. It gets pretty complex here. Please ask your improvement advisor, or you can seek myself, Kathy Tritton. There will be contact information we'll share, and I want to know if you have specifics about these determinations. We welcome the chance to answer them. In the documentation or the toolkit that you will be receiving, there are specific CCS lists that detail what's going on with the cancer diagnoses and naming psych diagnoses. And then for each one of these determinations to include or exclude as a readmission, there are also a list of CCS indicators that match each of the bullets that you see. If that 30-day readmission still has not met any of the criteria on the page, this is named as a readmission. It becomes a numerator source.
Okay, thank you so much, Kathy. Now I'd like to point you to some resources you can use that will have this information in written form. As you all know, we do have a Compass HIN toolkit that provides resources for every measure in our measure set. We're getting ready to release this week a new version of the toolkit that will be made available on the IHC website as well as through Hinnovation. This will have an updated resource section for readmissions and care transitions. Included in that is a new measure methodology report that details some of what we've had discussed here today as far as the 30-day readmissions measures. A link to that document will be found in the toolkit. As Kathy mentioned, for some of the inclusions and exclusions, if you're looking for the actual codes, we've included tables of those codes in that report. We appreciate the opportunity to overview the 30-day readmissions measures. Thanks and have a good day.